Hi guys, so today I wanted to film a video about understanding paediatric observations or vital signs. Now this video isn't going to be about the normal values of heart rate, respiratory rate, things like that. It's about actually what you're looking for in taking these observations and what that might suggest is going on with the child. Now this isn't extensive. I'm not going to be able to list an extensive list of what might be going on with different kind of observations being abnormal, but I wanted to kind of be able to give you a general idea to help you in placements, particularly if you're in your first year first placement, as many students kind of think that doing observations is being able to know what's normal and what isn't, and being able to plot them correctly on the graph and being able to take them correctly. Now obviously being able to take them correctly and understand them is really important, but that's kind of thing you'll learn at university and at placement, and it's also something in terms of the values that you just have to memorize. There's not really a way that I can kind of teach that or add to your learning in that way, but I think one of the things that's really important is understanding why you're doing observations and what the different observations means, and how to kind of go further in your observation skills as a student nurse. So as I say, I can't cover every single type of observation, every single kind of clinical outcome or clinical diagnosis that a child may have, but in this video we're going to look at the heart rate, respiratory rate, temperature, blood pressure, the visual appearance of the child, AVPU, and the capillary refill time. And I'm just going to go through each one of those and just giving a brief explanation and trying to help you to assess a patient well and kind of understand, going into more depth about the observations you'll be doing. So first of all, heart rate. Now heart rate is often talked about in terms of the beats per minute a heart is beating, and I'll put a little square here about the normal values for each range. Again, as I say, you'll have to just memorize those things, but I wanted to kind of talk about some of the jargon around that, what the heart rate, what's important to look at in the heart rate, and what the heart rate might tell you about the patient. Now one thing that I want to talk about is that heart rate, or assessing a child's heart or pulse, isn't just about the beats it's beating per minute. It's also about how that pulse feels. Is it regular? Is it weak? Or is it strong? And how that child is behaving also. For example, are they in pain? Are they scared and in a lot of distress? So I'm going to pick up on three words that are kind of jargony and important for you to understand. Tachycardia is when the heart is beating faster than the normal range for that child's age. Bradycardia is when the heart is beating slower than what is normal for that child's age. An arrhythmia is when the heart isn't beating in a normal, regular rhythm. And there are many, many different types of arrhythmia a child may have. One of the more common types of arrhythmia in children are SVTs, or supraventricular tachycardias. This is when extra beats or electrical activity come off the AV node in the heart, causing the heart to beat a lot faster. Now in terms of what we might be looking at when we're feeling a pulse, when we're seeing are they tachycardic, are they bradycardic, is the heart strong, is the pulse weak, is it regular, is most commonly fever. Now a child with a fever will usually be tachycardic. As the body is trying to fight infection, the heart rate will increase slightly. Now a child with a very, very increased heart rate and a fever may indicate sepsis, or they may even be going into shock. So this is a red flag symptom that you need to be aware of and able to kind of go to your mentor or tell another nurse about. The other condition that we have already mentioned are arrhythmias, where the heart is beating irregularly, and you'll often feel this on a pulse, whether that's very, very fast or irregular heartbeat. When the pulse is very weak, that might be a symptom again of sepsis. It may be a symptom of dehydration and shock. Very, very severe dehydration and shock, you would get a weakened heart rate. It may also be an indication of circulatory issues in a certain part of the body. For example, if you have a child with a broken leg and they have weak pulses in their feet, that might indicate they have poor circulation to their feet. Again, that's urgent and needs orthopedic review straight away, and you need to tell your mentor about that. Now, I've mentioned shock already. You can go into shock because of infection and sepsis. You can also go into shock because of loss of volume. So a child that is bleeding lots and lots may have a regular heartbeat. They may have a very fast heartbeat. They may also become bradycardic, but bradycardia in children is usually a peri-arrest sign and is very bad sign, the same as if a child who has had a fever and has been tachycardic, who then suddenly whose heart rate then suddenly comes into the normal range. That doesn't necessarily mean they're getting better. That could actually mean they're decompensating and getting worse, and you need all the other observations and their visual appearance to kind of assess what's going on with that child. Another thing to look at is head injury, because head injury with intracranial pressure can cause the heart rate to be low, so it can cause bradycardia if there is intracranial pressure present. Looking at the less sinister signs of an increased heart rate particularly, you'd be looking at, is the child in pain? Is the child very distressed and scared? If you have a child who is really scared of you and you're trying to do the observations and they're kicking and screaming and crying, then the heart rate is inevitably going to be high and not accurate, and you need to be looking at the whole picture and how the child is holistically to assess them well. Now on to respirations and respiratory assessment. Again, respiratory assessment isn't just about the respiratory rate, although that is important, the amount of breaths a child is taking per minute. Again, I'll put up here a little table of what's normal in each age range. Now, a child that has increased breaths per minute would be called tachypneic, and a child with decreased breaths per minute would be called bradypneic. You also have words like apnea, which means a pause or a stop in breathing, and this is particularly quite common in children that are babies that are premature and in the special care baby unit. It may also be quite common in children that have certain medical conditions where they get frequent apneas. But assessing the respiratory rate isn't all that you do in a respiratory assessment. You also need to be looking at that child's chest and how they are breathing and how they are interacting with that. So you look at their work of breathing. Do they have recessions? That means sucking in, and that could be under the ribs, subcostal in recession, in between the ribs, intercostal recession, or right in the middle of the chest, which is an indication of severe respiratory distress, and that's called sternal recession. They may also have tracheal tug, where they're sucking in the trachea here, just like that. Small babies may have nasal flaring, where they're trying to get a lot of air in and their nose is opening quite wide to try and bring that air in. They may also have head bobbing, where they're moving their heads up and down in an effort to get enough air in. All these signs are signs of respiratory distress and can be mild, moderate, or severe. You also need to be looking at breath sounds. Now, some people as student nurses think that it's something that you do later on in your nursing, maybe when you're in your second or third year, but I would start this straight away as soon as you're in your first year, even if at first you don't really know what you're listening to. The way that you get to know breath sounds and get to understand what different conditions do to the chest and what sounds they produce, the better you'll get at it, and the more accurately and the more kind of in-depth your observation of that child will be. So in terms of breath sounds, you may get crackles on the lungs, you may have a wheeze. Those are the most common types of sounds. You can also get quite a lot of different sounds with different conditions. As well as looking at the respiratory rate and the work of breathing, you also need to look at, are they able to talk to you? Are they talking in full sentences? How active are they being? Because a child that has got severe respiratory distress will not be able to talk in full sentences. They will also start to be tiring, and a child that would normally at home be very active and running around may just be lying flat on the bed because all they have energy for is trying to maintain their respirations and their oxygen levels. Measuring oxygen levels is also a really important observation that I've kind of thrown into the respiratory assessment, although oxygen levels can also be affected with cardiac illness as oxygen saturations give a really good indication of how much oxygen is getting through the lungs, how much those lungs are obstructed or restricted, and how sick that child is. So the most common childhood illnesses that you'll see in the hospital related to respiratory illness would be bronchiolitis, which is a viral illness that affects the bronchioles in young children, and it usually affects children kind of under the age of 2 or 3. It can affect you up to 4 or 5, but usually it's very young babies and toddlers. Asthma is also common. Asthma is often not diagnosed until a child's over the age of 5, but under the age of 5 they might be coming in with viral induced wheeze, and you can get wheezy children and wheezy breath sounds in children with difficulty in breathing associated with wheezing younger than 5. Asthma is usually diagnosed when they're over 5, as many children with viral induced wheeze grow out of it by the time they're 5, but children that are truly asthmatic will receive a diagnosis of asthma once they're 5. And the other common cause for respiratory illness in children are chest infections like pneumonia that require antibiotics. The next observation that I want to talk about is taking a child's temperature. Now, most commonly in the hospital you take this on a tympanic thermometer, meaning that it goes into the ear. Tympanic thermometers shouldn't be used on children under the age of 1. They often are in the hospital, I've seen it many times, but actually that's not going to be accurate and it could actually damage their eardrums. Children under 1 should have their temperature measured under their armpit with an auxiliary thermometer. So children obviously can be too cold, which we call hypothermia. This is quite rare. I've seen it, I'm not actually sure that I've seen it at all, apart from when we've purposely made children hypothermic to prevent brain injury. Most commonly you have fevers, which are often called pyrexia, or a febrile child is kind of the jargon that's used around that. It's very common to see children under the age of 4 or 5 coming in for febrile convulsions. Now, these are fits or seizures or convulsions that are caused by a sudden increase in your temperature. Now, many people think that it's caused by very high temperature, but there's not really any indication or evidence to suggest that how high a fever is makes you more likely to have a febrile convulsion. It's usually how quickly the body goes from kind of having a normal temperature to having a high temperature, even if that's just an increase of like 0.5 degrees. That might be enough to induce a febrile convulsion in a child. It's also just how an individual child reacts to having a fever. Some children are just more likely to have febrile convulsions and other children will never get one, even if their fever is very high. The other thing that I wanted to add to that is how high a fever is does not indicate how severe an illness is. A child may have a very, very high fever but have quite a mild viral illness. Again, a child might have a relatively mild fever but have a very severe illness. So it's important not to rely on a child's temperature to tell you how sick a child is. Now, blood pressure isn't always routinely done on children, as children do not drop their blood pressure when they are severely sick until their peri-arrest, meaning that they don't drop their blood pressure until they're pretty much about to go into respiratory or cardiac arrest. It's a very, very late sign. So on children that come into hospital relatively well, we don't always have to do a blood pressure on them, but there are certain cases where we would want to do a blood pressure. Blood pressures are very important in head injury, and every child that has come in with a head injury should have regular blood pressure monitoring. This is because intracranial pressure caused by head injury can increase your blood pressure. As we were saying earlier, it can decrease your heart rate and increase your blood pressure, so it's very important to keep an eye on blood pressure. Blood pressure is also important if you have a child with renal illness or cardiac illness, as those illnesses can also affect blood pressure and tell you quite a lot about how a child is coping. It's also very important, as I said, in the very sick children, as blood pressure won't be dropped until peri-arrest, and it can really give you a good indication of how sick a child is. It's also important for children that have dehydration or potential hypovolemic shock, which is shock caused by a lack of volume. So that can be either by severe dehydration or by fluid loss, such as blood loss from an injury, because when they're in hypovolemic shock also they will start to drop their blood pressure. Now, low blood pressure we call hypotension, and high blood pressure is called hypertension. And the other observational skill that I want to talk about that is so important, and almost I would say one of the most important things, is how the child appears visually. What do they look like? What are they doing? What does their skin look like? Again, I kind of touched on this about, is a child just laying flat on their back, not moving when they're 2 years old, and ordinarily they would be up and jumping about and going crazy? Are the children acting as their normal self? Are they confused? Are they dizzy? Are they able to walk in a straight line? You're particularly thinking about that with neurological observation, even though I'm not going to go into detail about neurological observation in this video. You are kind of looking at those things in the visual assessment as well. What is the colour of the child like? Are they pale? Are they blue, which we call cyanosed? If they have blue lips, they might have blue fingertips, they might have blue feet. Again, that's quite a severe sign of circulatory failure. It may also be a sign of underlying cardiac disease, especially in babies that come in cyanosed but appear otherwise well. They might have underlying cardiac disease. Children will also be cyanosed if they have very low oxygen saturations. Is the child mottled? Now, this is like a purple, almost netting of the skin. I don't really know how to explain it, but you'll see it in practice. And it's kind of purple lines all over the skin. Now, some babies are just mottled naturally, and it's important to ask the parent, is this how do their arms or their body or their legs usually look like this? Because if they always look like that, it's not necessarily anything to worry about. But if it's unusual for them, it could again indicate a problem in their circulation. This is all because when a child is trying to compensate, the body will automatically suck all its resources, all its oxygen and blood supply to the major organs, the heart and the lungs and things like that. So you might get in the arms and in the legs mottling, cyanosis, things like that, and it will show you if a child is trying to compensate. Is a child very sweaty? Again, this might indicate a fever, it might indicate shock. Rigors is also another indication of illness, and fever in particular. Are they shaking? Visual appearance of a child in terms of sweating and shaking and paleness as well might indicate something like type 1 diabetes going on as well. So you might, in those situations, if there's not another indication for what's going on, might want to do a blood sugar monitoring on them, but that is not routinely done in children. It would only be done if there were particular signs of hyperglycemia or hypoglycemia. Next, I want to talk about AVPU. This is kind of a very quick neurological assessment, and it stands for alert, voice, pain and unresponsive, and it's just a really quick way to assess a GCS, or it's kind of a pre-GCS assessment, because GCS is a lot more kind of in depth, and for a child that isn't coming in with anything neurologically wrong with them, you might not necessarily need to be doing GCS on them. But it's important to know if they're alert, if they're only responding when you call their name and they're not really waking up. If they're only responding to pain, again, is a sign of a very sick child. If they're only responding when you're kind of rubbing their chest or shaking their shoulders or squishing their hand, that's again a very severe clinical sign. And if they're unresponsive when they're not responding to any of those things, and you'll see this sometimes when you have young children and you're putting cannulas in and they're just laying flat and they're not crying, they're not responding to that, that's a sign of a very, very unwell child. And the only other thing that I wanted to touch on is capillary refill time. And this is when you push on either the fingers or toes or the middle of the chest for 5 seconds and see how many seconds it takes for the colour to return back. This is usually less than 2 seconds, and that would be considered healthy. Again, if it wasn't like that, it would be a sign of circulatory problems and the child trying to compensate for illness. And if a capillary refill time is very severe, like above 5, then that is again a very severe indication of kind of circulatory failure. So this has been a really, really long video, but I really hope that it's helped you. I really hope, obviously it's not extensive, I've not covered every single possibility, I've not covered every single observation, but I hope I've given you the basics to be able to go into placement prepared, to know what you're looking for, to know why observations are important. And please don't think that all you're doing is learning how to do an observation and chart it, because it is really important that you know why you're doing those observations and what those observations may mean for that child, and when you need to seek help, what kind of nursing care then that child needs to receive. This is part of being a nurse. It's not just about being able to physically do it. And you know, our lecturer used to say Joe Bloggs could come off the street and you could teach them how to do observations, and it is pretty simple to know how to do observations. It's another thing to be able to understand what you're actually doing and why. So I really hope that helped, guys. Thanks so much for listening. If you've got to the end, well done, and I wish you all the best for placement. Bye.